Welcome back to Dr. Jagdish Academy. In today's lecture, I will discuss about the pharmacology of renin-angiotensin system. So let's start. In this video, I will discuss in brief about the functions of renin-angiotensin system. Then what are the therapeutic uses of drugs that modulate the renin-angiotensin system? What are the side effects, contraindications, and what are the different drugs? Okay, so let's start. So if you discuss about the renin-angiotensin system, it starts from the juxtaglomerular cells, which are also called as JG cells of the kidney. These cells, they respond to activation of beta receptors, okay, which are the part of sympathetic nervous system. Okay. So if you want to discuss more about the beta receptors and their role in relation to the juxtaglomerular, you can go and click to the link which is given in the description section of this video. Okay. Then activation of sympathetic nervous system or the beta receptors or the decrease in blood flow is sensed by these cells. So then they release a hormone in the blood which is called as renin. This renin acts on the protein called as angiotensinogen. So this angiotensinogen is converted into the angiotensin 1. So that means you can see renin leads to the formation of angiotensin 1. And this angiotensin 1 is a short peptide, okay, comprising of 1 to 10 amino acids. Then this angiotensin 1 is not that biologically active. So there is another enzyme called as angiotensin converting enzyme, which is also called as ACEase. It converts this angiotensin 1 into angiotensin 2, which is shorter than 1. It has 1 to 8 amino acids. This angiotensin 2 is biologically active. It acts on AT1 receptor, angiotensin 1 receptors. These receptors are activated, leading to the vasoconstriction, okay, increase in vasoconstriction. That will lead to increase in the peripheral resistance. Resistance in the arteries will be increased. That will lead to the increase in the blood pressure. Similarly, angiotensin 2 leads to the release of this hormone aldosterone from the adrenal gland. This aldosterone, it increases the sodium and water retention. So because of this retention, there is increase in the cardiac output. So this cardiac output leads to the increase in the blood pressure. Another thing, these receptors lead to the activation of the thirst center. More water intake is there, and as a result there is increase in cardiac output, so blood pressure. So you can see these angiotensin 2 through the increase in peripheral resistance and through the cardiac output, it produces the increase in blood pressure. Now, this is the physiology. Coming down to the pharmacology. So we are having the drugs which are direct renin inhibitor, and that means they inhibit this step, renin. Renin is inhibited, and the drug is L-scarin. And then a very important category, ACE inhibitors. They inhibit this enzyme ACE, and one of the prototype drug is enalapril. Then AT1 receptor blocker. They block these receptors. And the prototype drug is telmisartan, candesartan, these kind of things. So in the subsequent sections, I will discuss about these drugs. What are their uses, side effects, contraindications. So you have to remember this chart. So that means they are increasing vasoconstriction, sodium water retention, okay, increasing cardiac output and resistance. So coming down to therapeutic uses, first use is in the hypertension. So you can see these drugs, angiotensin converting enzyme inhibitor or the AT1 receptor blocker, they are the drug of choice in most of the hypertensive patient unless it is contraindicated. They are very effective, they have minimal side effects, and they do not interfere with the routine activity of the hypertensive patients. So what is the mechanism? As I discussed in the previous slide, their major mechanism is that they produce the vasodilation. Angiotensin produces vasoconstriction. So if you block angiotensin 2, so vasodilation will be there. Vasodilation will lead to decrease in peripheral resistance. Second, they reduce the cardiac output because sodium will be reduced, water will be reduced, cardiac output will be reduced. As a result, blood pressure will be reduced. So you can discuss with the previous slide. So you can discuss, you can see this is how they are acting as antihypertensive drugs. Second use in the congestive heart failure. So you can see again, they are the drug of choice in almost all stages of CHF until it is contraindicated. Okay. So what is their benefit? They reduce the symptom of congestive heart failure. That means if the person is taking this medicine, the symptoms will improve. What are the symptoms which are improved? There is a congestion in the body. Lot of fluid is there in the body. Edema is there. Difficulty in respiration, dyspnea. So these symptoms are slowly improved with these drugs. And more importantly, they reduce the mortality in CHF patients. The survival time is increased in these patients. Okay. So now coming down to the what are the mechanisms? How these drugs are effective in CHF. So there are 4 mechanisms I will discuss. First is the reduction in preload. What is this? You can say they are vasodilators. So they dilate veins. If the veins are dilated, so the amount of blood going to the heart will be reduced because veins they return the blood to the heart. So reduction in the blood returning to the heart, venous return will be reduced. If venous return is reduced, you can say there is a less load on the heart. So as a result, if the load is not there on the heart, so heart contractility will be better. Okay, so this is one mechanism. Second thing, they also reduce the afterload. Afterload means they dilate the arteries also. So you remember, they dilate veins as well as they dilate arteries because there are certain drugs which selectively dilate veins like nitrates. There are some drugs which dilate only arteries like CCB, calcium channel blockers, hydralazine. I will discuss in upcoming videos. So they dilate both veins as well as arteries. So if the arteries are dilated, so you can say the resistance will be reduced. Reduction in the resistance in the blood vessels, in the aorta arteries. Okay. So what will be the effect? Now heart is pumping in this aorta, in these arteries. If the resistance is less, there is lesser load on the heart. So what we can say, heart has to pump in less resistance vessels. So obviously you can say the improvement in contractility. So these are 2 very important mechanisms: reduction in preload, reduction in afterload. So I am continuing with the mechanism. Third mechanism, they reduce the congestion. How? Because angiotensin increases sodium and water. They reduce the sodium and water retention. As a result, fluid volume will be reduced. If the fluid volume is reduced, congestion is overcome. If congestion is not there, then dyspnea will not be there, edema will not be there. This is how the symptoms are overcome. And another very, very important mechanism, decrease in cardiac remodeling. Remodeling means restructuring, reshaping. So what happens is that if there is a long-term CHF, then there is a fibrosis that takes place in the heart. Fibrosis means the contractile portion of the heart, the functional part of the heart, is slowly replaced by the fibrous tissue. Fibrous tissue is not contracting. Okay. So if fibrous tissue is there, so you can say contractile will not be there because now it is the fibrous tissue, not the contractile tissue. But if you give these drugs, they reduce the fibrosis, contractility will be retained, and as a result, person's survival will increase, mortality will be reduced. So these are 4 very important mechanisms of angiotensin converting enzyme inhibitors or the ARB. Myocardial infarction. Now it is found that if the person is undergoing myocardial infarction, that means heart attack has taken place, and if you give during first 24 hours and you continue to give for at least 6 weeks, it is found that the early mortality, that is mortality in the hospital, and long-term mortality is reduced. So they reduce the chances of mortality in the patients suffering from myocardial infarction. Very important use. And moreover, if you give these drugs in the unstable angina patients or the non-STEMI is a type of MI, but it is a less serious form of myocardial infarction. If you give these drugs in this one, so the chances of reoccurrence or the occurrence of myocardial infarction, the serious form of the myocardial infarction is reduced. Fourth, high cardiovascular risk patient. If you see a person is hypertensive, angina, okay, so these kind of things are there, and you can say these are the risk patient, cardiovascular risk patients. So they can be used as prophylactic agents so that the disease doesn't progress. So what you can say, they reduce the adverse events in the high risk cardiovascular patient. The person's survival rate is increased, the lesser chances of adverse effects. Okay, so this is the another use. Then another use is diabetic nephropathy. You know, diabetic nephropathy is a complication of diabetes, in which there is a dysfunctioning of the kidney. Proteins start appearing in the urine. Okay, so this is nephropathy. Now it is found that if you give these drugs for a long period of time in diabetic persons, whether it is type 1 or type 2, they reduce the occurrence of the you can say the progression of the end-stage renal disease. The incidences of nephropathy, they are reduced if these drugs are given in diabetic person. This is the thing that has been found in the patients. Last use that I am discussing with you is the scleroderma crisis. Scleroderma is actually also called as systemic sclerosis, is an autoimmune disorder, mostly occurring in the females, but not very common. It is a rare disease. Okay, so there are many things in the scleroderma, but I am telling just one point, that there is a hardening and thickening, tightening and tightening of skin and connective tissue. They become very hard. As a result of that, sometimes it becomes a serious condition, crisis. In that condition, there is a very high blood pressure and renal functioning is deteriorated, and that is because of a very high angiotensin too. So if you give these drugs, okay, then they can produce the improvement, and they can be life-saving in these kind of the patients. Coming down to the side effects. Uses are very important, as well as side effects of these drugs are very important. I will discuss side effects one by one. Dry cough, a very important, side effect. Now you have to see, differentiate. This side effect is with ACE inhibitors, not with the AT1 receptor blocker. I will discuss at the end why. Okay, so remember, with ACE, not AT1. So that means if the person is having a dry cough, you can use AT1 receptor blocker instead of ACE inhibitor. Second is angioedema. Angioedema is a type of allergy, and there is a swelling of lips, face, tongue, larynx, these kind of things. Okay, so if you compare these two, ACE inhibitors and AT1 receptor blocker, it is more common with the ACE inhibitors, about 1%. Particularly if the community is black people, very common. But incidences are very less with angiotensin receptor blocker ARB, with this one. So that means if the problem of dry cough, angioedema, then you can choose the AT1 receptor blocker. Otherwise, they are very similar to one another. Major difference is that the advantages of AT1 is that there is no dry cough and lesser incidences of angioedema. Then, what is the reason? What happens is that if you give these ACE inhibitors, they inhibit the metabolism of bradykinin. Bradykinin is not metabolized. As a result, the levels of bradykinin will increase, and increase in bradykinin is responsible for cough and angioedema. So that is why they are more common with ACE, not with AT1. Third, hyperkalemia, rise in potassium, a very important side effect that you have to remember. They produce a rise in serum potassium level. So that means you have to take care that person is not taking extra potassium. potassium supplements, or person is not using potassium sparing diuretics like spironolactone, if the person is taking both ACE inhibitors or spironolactone, then you have to monitor the potassium serum level and you have to reduce the doses accordingly. Otherwise, there is a dangerous hyperkalemia that can take place. Then another is teratogenic. Don't give these drugs during pregnancy. They have a deleterious effects on the fetus. They will retard the fetal growth. The organs, the bones will not be formed, hypoplasia, and the death of the fetus can take place. Another side effect, hypotension, particularly with the first dose, sharp fall in the BP. So, in order to prevent this one, start with the low dose. Nausea, vomiting is there sometimes. Sometimes there is a taste alteration, dysgeusia. This is more common with a drug called as captopril because it is a sulfhydryl group containing, lesser with others. Then this is an important thing, acute renal failure. Not in all, in some patients. The patients which are suffering from bilateral renal artery stenosis. It means bilateral means both renal artery, two arteries supplying to the left kidney and to the right kidney, stenosis. The blood vessels, they are narrowed. Stenosis has taken place. So if this kind of the patient is there, if you give these ACE inhibitors or ARB, then acute renal failure can be there. So this is a contraindication. Don't give these drugs in bilateral artery stenosis. So this is second contraindication that I am telling. First, it was in pregnancy. Second is acute renal failure can take place in these patients should be done. And the last side effect that I am discussing is that they produce renal dysfunction. This is almost in every patient, this which I am telling. So it is found that if you start with the drug therapy with these drugs, there is a rise in serum creatinine levels. Creatinine is a waste material which is excreted. Okay, so if renal dysfunction is there, the levels of serum creatinine increase. So in order to prevent this one, start with the low dose. Okay, and increase the dose slowly after a few weeks, 7 to 12 weeks. And if you monitor and the rise in serum creatinine is less than 30% of the baseline, then it is acceptable. That means, but if the rise in creatinine is more than 30%, then reduce the dose. And if creatinine is more than 50% of the normal value, then stop the dose. So stop the dose if more than 50, more than 30, reduce the dose, less than 30, then it can be accepted. Now some important drug-drug interactions. Hyperkalemia, as I told, they produce increase in potassium levels, so the drugs, potassium sparing diuretics, potassium supplement, or if you combine both ARB and ACE inhibitors, then dangerous hyperkalemia can take place. So monitor potassium levels. Enhanced hypotension, you have combined two drugs, diuretics plus ACE inhibitors, so they enhance the hypotensive effect. So monitor BP. Reduction in hypotensive effect, that means you are giving ACE inhibitors, but the effect is not coming because it may be possible you are giving NSAIDs because they produce fluid retention and they overcome the effect of ACE inhibitors. So monitor BP. They enhance the lithium toxicity. You remember lithium is used as anti-manic agent. So you are giving ACE inhibitors and lithium. The dose of lithium has to be reduced. Otherwise, lithium toxicity will increase. Then I will discuss some individual drugs. Coming down to captopril. I will not tell in detail and just few points. Captopril, it has a sulfhydryl group and food interferes with the absorption. Enalapril. Enalapril is a prodrug. It goes into the liver, acted upon by the esterases and forms a enalaprillate, which is an active moiety. Now it is more potent than captopril. Actually, all the drugs which are formed after captopril, they are more potent. So this is also more potent, and it is given once a day. Food doesn't interfere with its absorption. Then lisinopril. This is a lysine derivative of enalaprillate. So obviously it is not a prodrug. Single time a day, so food doesn't interfere with the absorption. Then another drug is perindopril. It is long acting and long and slow acting. So what is the advantage? Because it is slow acting, the chances of hypotension are very less. So this is again converted into the perindolet by esterases. Okay. For sinopril, now it is advantage that if the person is having a renal disease, then there is no need of you can say dose adjustment. That means what I am telling is, if the person is having a renal disease, so you have to go for a dose adjustment. Okay, but for sinopril can be given no need of dose adjustment even if the person is renal disease, because it is extensively metabolized by the liver. It is pro-drug, long-acting. Then some other drugs, I will name the drugs: ramipril, quinapril, prendopril. Then these are benazepril, like these kind of things. Now coming down to the AT1 receptor blocker, I will just name the drugs: losartan, candesartan, irbesartan, valsartan, olmesartan, then telmisartan, and aprosartan. Coming down to the last drug, direct renin inhibitor. Now the drug is aliskiren. This is a non-peptide, bind to the catalytic sites of the renin. So you can say, because it binds to the catalytic site, so it is a competitive inhibitor. So it inhibits the conversion of angiotensin into the angiotensin. Now the important point of aliskiren is related to pharmacokinetic. It has a very low bioavailability, just 3%. So it is alternative to ACE inhibitors of ARB. That means if you cannot give ACE inhibitors or ARB, then you can give aliskiren. Dose is about 150 to 30 mg per day. Okay. Now in the upcoming video, I will discuss about the calcium channel blocker, their therapeutic uses, their side effects, along with the contraindications. Thank you.